Welcome to session 3 of Addressing Breast Density and Risk in Primary Care Echo, where we will be learning about supplemental screening options, including harms and benefits. If you have a question, don't hesitate to ask. Raise your hand, come off mute, or put it in the chat at any time. This is intended to be a very interactive session. We don't want you to just sit and listen today. We want to hear from you. So please, you will gain the most out of this session if you interact. After we get through all of the housekeeping items and welcome and introductions, then we will go into our didactic presentation with Dr. Slanitz, and then we will go into our group case discussion, and then we'll have time for feedback and our survey and wrap up. And with that, it's my pleasure to turn it over to Molly.
Oh, so great to join you all this afternoon. Just want to remind you of this amazing Echo. It says Hub Team. We refer to them as the Dream Team with Dr. Cresson, Dr. Battaglia, Dr. Gunn, and Dr. Slanitz. You're going to hear from Dr. Slanitz in just a moment. Next slide. Just want to ground everyone in the goal and our objectives for this Echo. It's really to advance the understanding and the role breast density plays in a patient's overall breast cancer risk and how to communicate options. And we're going to learn a lot more about what options are out there today. And then, by the end of this ECHO program, we want you all to have the knowledge to communicate risk and provide primary care for patients with dense breast and to integrate breast cancer risk assessment into primary care practice. Next slide. So quick recap from our last session, and the recording link is there. If you missed it, highly recommend you schedule some time on your calendar and rewatch or watch that rather. So we talked a lot about how breast density significantly impacts mammographic sensitivity. It masks cancers, it reduces sensitivity, 85 to 89% in fatty breasts to 62 to 68 in extremely dense breast. This masking effect leads to higher rates of interval cancers. So those cancers in between the recommended screening and later stage diagnosis, which does reduce the mortality benefits from screening. And breast density is a risk factor, but not the most predictive risk factor. And then the clinical and regulatory changes require patient notification through the FDA and started in September 2024, although many states had a version of this prior to that. Okay. Now you're up to speed on what we did last time, and I have the pleasure of turning it over to Dr. Slanitz to talk more about supplemental screening options and those harms and benefits of the options. Take it away, Dr. Slanitz.
Okay, thank you, Molly. So this is going to be a quick overview in 20 minutes. We're going to go through all the different imaging options that we have, and then we're going to be concluding afterwards, sort of introducing some of the societal guidelines and organizational guidelines that exist. But Dr. Battaglia will be talking more and more about that at the next session. So let's go to our next slide. These are just my disclosures. So the learning objectives for today are to understand the benefits and downsides of supplemental screening, to become familiar with the different modalities that you can potentially order, and then sort of just review or sort of introduce the societal and organizational guidelines that do exist for supplemental screening in women that have dense breast tissue, and even for those who don't have dense breasts, because we're going to talk a little bit about risk as well. So let's go to our next slide. Yes. Feel free to ask any questions at any point. I'll try to keep an eye on the chat. So just to recap, and I guess Molly just gave us a recap, but why are we even talking about supplemental screening for women with dense breasts? Well, first of all, we do recognize it's now an independent risk factor for breast cancer, and the mammographic sensitivity is going to be lower in people that have dense breast tissue on their mammogram due to the masking effect. And it's well known that women with dense breast tissue, particularly the extremely dense category, have a higher interval cancer rate, meaning that they will potentially have a cancer that appears in between the screening interval, so a negative mammogram and before they're due for their next mammogram screening. So, we want to try to find cancers early, and that is really the reason why we're talking about doing additional screening, particularly in women who have dense breast tissues. So, what are the benefits? The benefit is that you're going to find more cancers at an earlier stage. So, an early detection with a lower stage will be less morbidity. So, fewer women will need to undergo extensive surgery or even have systemic chemotherapy. And some of them might even be able to avoid radiation therapy. So, that's a real huge benefit. But keep in mind that it has not been shown that there's any mortality reduction from supplemental screening. Mainly because nobody's ever designed that study to do it. And I would say that the technologies are changing so rapidly that would be a very hard study to do. And therefore, many of the studies that are looking at some of these technologies are actually using a reduction in the overall number of interval cancers as kind of a surrogate marker for potential mortality benefit. And so that's how many of the studies are now being designed. So next slide. So what are the downsides? Because, obviously the more you image or the more tests you order, the greater the chance that you might actually have a false positive. And okay, so there is a question in the chat about very dense tissue. Would ultrasound be better? We'll get to that in a minute. So we'll hold on to that question. But the downsides of doing any kind of supplemental screening is that you might have false positives, meaning that you may call somebody back to have either additional imaging and potentially to undergo a biopsy that turns out not to be cancer. And some people are concerned about that short-term anxiety that women suffer, but there's actually been multiple studies now showing that most women, majority of them, would prefer to have a little bit of anxiety to know that they don't have a breast cancer. So I think although there could be some false positives, obviously, for many women, they would prefer to undergo that additional testing if they need to. There is the potential for overdiagnosis, meaning that you find a cancer or a precancerous lesion that may not have affected the patient during their lifetime. And most of us believe that, there is certainly some overdiagnosis, but we really feel that it's actually quite low because when we're doing supplemental screening, we're predominantly finding node negative invasive cancers that are very small rather than the ductal carcinoma in situ. And we know that ductal carcinoma in situ, which is technically a precancerous lesion, is probably overdiagnosed because if that particular entity is left alone, only about 30% of them will actually go on and become invasive cancers. But in general, the feeling is with the supplemental screening, the risk of overdiagnosis is quite low. The other downside, potentially depending upon where you're practicing, is that it could potentially cost the patient some money financially because not all insurance covers the supplemental screening exams. Now, there are more and more states that have passed some legislation that provide coverage for the supplemental screening tests, but it is not uniform across the United States. There is a law that's been put into, or well, it's now been resubmitted to the federal government, the Find It Early Act, which would provide that coverage if it does pass. And obviously, there's a push to get that done so that uniformly across the United States, women would have access to supplemental screening at no out-of-pocket costs, but we're not there yet. So let's look at our next slide. So this is actually a map from densebreastinfo.org. Really, really great resource, both for patients and providers, but just to show you where we are in 2025 with certain states, you can see are in green, and you can see that they have that have insurance laws that provide coverage for whole breast screening, ultrasound, MRI, and other tests. The one in blue only does it for diagnostic breast imaging, so not necessarily for supplemental screening. But you can see that there are multiple states across the country that still have no laws for any kind of expanded breast imaging coverage. So there's still a lot of room to go. And I think this Find It Early Act, because it would be federal, is probably the best approach, provided we can get that through the legislature. So let's go to our next slide. So here are our current screening options, and we're going to talk about all of them: digital breast tomosynthesis, ultrasound, MRI, contrast enhanced mammography, and molecular breast imaging. So let's go to our next slide. So the way to think about these different modalities is that they're looking at different kind of aspects of cancers. So the ones that we do most commonly, which is full field digital mammography or digital breast tomosynthesis, so that's which is just a specialized mammogram, as well as whole breast ultrasound, are really looking at the shape and morphology of a tumor. So it's looking for that growth of tissue. And so that's kind of a very macroscopic approach. When we introduce MRI or contrast enhanced mammography, where we're actually administering a contrast agent into the vascular system, we're then trying to find tumors that have neovascularity, so they've developed blood vessel growth. And that's how we're going about to detect the cancer. So you can imagine if we're looking for blood vessel growth, you're going to find probably cancers that are even smaller than the ones that might be detected on the technologies that are relying mainly on morphology or shape of a tumor. And then we'll talk briefly about molecular breast imaging, which really is imaging at more the cellular level. It is not as widely available, but there's some pros and cons to obviously all of these different approaches. So let's go to our next slide. So what is digital breast tomosynthesis? Now, I would say in many cases now it is being performed at the same time as a routine screening mammogram, but sometimes facilities are not using it uniformly and the patient may only undergo a 2D or two-dimensional acquisition. But basically what it is a volumetric acquisition. So the X-ray tube, once the patient's been positioned, is actually rotating through an arc and acquiring somewhere between 15 to 50 actual separate acquisitions, and then it will process that data and make it into a sort of a slices of the tissue that you can now actually pan through in 1 millimeter thick slices. So if you hit the next, we should have this animation so you can see how the X-ray tube would move. And then we click again, Mindy. Sorry. So I'm showing you on the left side here is just the two-dimensional mammogram, which is just read as extremely dense. And then we have our slice. This is a thin 1 millimeter slice. And actually what you can see here, and Mindy, if you just click one more time, because I've magnified up this area, you can see how the tissue is being pulled into this central point here, rather than all just heading towards the nipple. And this is what architectural distortion looks like. And this was actually a grade 1 invasive ductal cancer. So it has the ability to find cancers. So let's go to our next. So I just made a table for each of these. So the pros of digital breast tomosynthesis is it is going to increase your sensitivity, particularly in women with dense tissue, but it's not going to be as helpful in women who have extremely dense tissue because it still relies on having a fat and glandular interface in order to help us to detect the cancer. We do find more cancers with it, but the incremental cancer detection rate is probably quite low. And it has not been shown to reduce interval cancer rates. So although we'll find a few more cancers, it may or may not have a huge impact on a patient's mortality. The biggest advantage to digital breast tomosynthesis, though, is that it will decrease the chance that a woman is called back to have something worked up on their mammogram that turns out to be benign. So it basically decreases that recall rate or the number of false positives by a pretty significant percent. So there's huge advantages in that realm. So fewer women are going to be called back for a false positive. It does carry a little bit more radiation exposure, particularly if they're doing a combination of the two-dimensional acquisition as well as the tomosynthesis acquisition. Although some facilities now just do a tomosynthesis acquisition and then will synthesize a two-dimensional mammogram from the volumetric data. So, but even with the synthesized, the actual tomosynthesis is still a slightly higher radiation dose than just a routine mammogram. The other thing is it does tend to find just sort of more of the low-grade tumors, which is okay because they need to be found too, but it's not going to be as effective for some of the more aggressive tumors. If it's being done, it's typically performed at the time of a routine screening mammogram. The other thing to note about digital breast tomosynthesis is although a majority of accredited facilities in the United States have it, you can see that only about 50% of the units are actually accredited to do digital breast tomosynthesis. So although they have it at all these facilities, not all those facilities, not all of their units have the capability. The other thing I would say is that it's also not uniformly available across every geographic part of this country, including in, my area in Greater Boston. Some of our neighborhoods that are of lower socioeconomic status actually do not have access to it, and it seems to be more concentrated in some of the wealthier and communities. So there's also a disparity in terms of access to this particular modality. All right, let's go to our next slide. So what about whole breast ultrasound? Now, whole breast ultrasound, what's great about it is it is widely available. And so you can do it handheld. So all you need is an ultrasound machine, or you can invest in the automated system, which will, either way, you're going to generate a lot of images. And, certainly the scan can take up to 20 minutes to acquire all those images and to scan the entire breast. But it certainly can work because here was a patient who's heterogeneously dense. She had a past history of a cancer and she wanted to have some kind of supplemental screening. For some reason, I believe she couldn't go into the MRI scanner. She had a contraindication, so she opted for whole breast ultrasound, and we found a invasive cancer in her left breast, not mammographically detectable, so it was mammographically occult. But I mean, so the modality does work, but it does have a reasonable callback rate, and up to depending upon the I guess skill of the radiologists that are doing the interpretation, uh, even up to a quarter of patients may end up either in follow-up or having a recommendation for a biopsy. So, that will improve over time as patients potentially have serial whole breast ultrasounds, but it's still a reasonable number of patients who have to undergo some additional imaging or even a procedure. Next slide. Sorry. Oh, the other thing I was going to say is that there was a study that shows that it obviously does not also pick up every malignancy. It misses at least 8% of cancers that aren't detected on either a mammogram or an ultrasound. So it will find some cancers. However, if we go to our next slide, you'll see that it does actually decrease the interval cancer rate. So there is some benefit potentially to doing whole breast ultrasound. The incremental cancer detection rate, though, will vary depending upon the risk that the patient has. So having dense breasts might not put them in the highest risk, but if you're higher risk, you may find 3 to 5 additional cancers for every 1,000 people we screen. And if somebody's more average risk with dense tissue, it might be only 1 to 3 per 1,000. But again, it is finding those node negative invasive cancers, and there's no radiation. The cost, that's a great question about mammo versus ultrasound. I think they're actually pretty similar. The costs are not, they're relatively inexpensive, both of these, which is good, right? Because it's not going to add too much in terms of, and in general, most of the time, ultrasound often is covered by insurance, but it's not uniformly covered again. So that's something that you'd have to check with the patient's insurance. The downsides of ultrasound is that the recall rate, the chance that they're going to be called back to have something else done, is reasonably high. And the positive biopsy rate, particularly as somebody's starting out doing the whole breast ultrasound screening, is actually quite low. So normally our positive biopsy rates for mammography and for MRI and for digital breast tomosynthesis range between 25 to 40%. And ultrasound, often the biopsy positivity rate is less than 10%. So for the women who are getting recommended, we end up doing a lot more benign biopsies just to find those few extra cancers. But it does work, and it has some benefit because the interval cancer rate does get lowered, at least to some extent. All right, so our next modality. So MRI is basically a high field magnet. So it's a very, very strong magnet. And there are different protocols that can be done. There's a full protocol, and many of you may have heard about abbreviated protocols, but abbreviated protocols just means that instead of after giving contrast, they do the 4 acquisitions, they'll only do 1 after they give the contrast. So it just shortens the time that the patient's on the scanner, but it's still the same modality. It does require that we give contrast through a vein. So it's gadolinium, which is a very safe contrast agent. Very rare that somebody would have an allergy to that. It does require the patient to lie on their stomach, and their breasts have to hang down into the breast coil. And basically, very short and stout women sometimes will not fit into the magnet because the magnet is a certain size. So there's certainly some patient limitations. But a majority of patients usually can fit into the magnet and have this test done, and it has a very, very high sensitivity and I think a very reasonable specificity. But as I said, some patients may not fit into the scanner. Some patients may have severe claustrophobia, so they're not able to lie still. And then others, may have, implanted devices like a pacemaker that makes them ineligible to go in, or retained metal in their body that prevents them from safely going into a scanner. But I mean, this was just a high-risk woman who had this linear area of enhancement that turned out to be ductal carcinoma in situ. So, it does find cancers. So let's go to our next.
Priscilla, before you move on, can I ask you a question about the abbreviated
Yeah,
versus the sort of full
yeah,
protocol?
absolutely. Yep.
So, is there a difference in sort of detection rates or sort of performance characteristics between the two? And why would you not use an abbreviated version if the answer is no, or if it's better?
So I think the full study is a little bit better overall, but probably not, for finding a significant cancer, there's probably not a huge difference. I'll just be honest with you. I think the data is showing that they're fairly comparable, but the full study would allow us to characterize the lesion a bit better because, basically the abbreviated, often you literally have maybe two or three total sequences. So you'll have a pre-contrast, one post-contrast, and maybe a T2 weighted sequence. And those three, if there's a finding, you can't fully characterize it sometimes.
So,
But
just
but overall, it's not. I think the cancer detection rate is pretty comparable.
from a clinical
Hmm.
ordering provider perspective, which I think represents most of our
Hmm.
participants today, do we care or do we request a specific
I would say
protocol, or
no.
we don't really have a
I
choice?
don't
It's
I
what
don't
the
think I don't think you really have a choice because
okay.
some facilities are doing abbreviated protocols and some are doing the full all the time. Um, you know, for patients who pay out of pocket, some practices charge a small fee to do the abbreviated. So, because the abbreviated for some places, it can be billed just like a regular MRI. There's no difference in the CPT code. But some facilities are now charging patients for abbreviated, which I think is wrong. I
Crazy
think,
because it's
I
cheaper for
think,
them to do. Oh,
right.
that's
Well, no, well, but I think it comes down to if you have a high deductible health plan and say your deductible is $1,000 and the you could, you're going to end up paying $1,000 for that versus you could maybe the place is offering it for 400 or $600, right? So you end up the patient may in the end pay less if they pay out of pocket. But I personally think,
yeah,
we
I hear
need
you.
coverage 100%. But in general, it's a very, very good test. So let's go to our next slide because we got to keep going. I don't want to get too far behind here. We want to have time for discussion. So as you can see, the pros are high sensitivity, high specificity. As I said, really the abbreviated has very similar sensitivity and specificity. And technically it should be lower cost because they're not on the scanner as long, but they are billed identically at this point because there is no specialized CPT code for abbreviated but the full protocol, honestly, most people are on the scanner for 15 minutes at the most at this point, and the abbreviated maybe is 5 to 8 minutes. So they're fairly comparable. Very, very high interval cancer detection, though, rate, which you can see like 10 to 25 per thousand screened. You're finding an additional 10 to 25 cancers. And in patients who are dense and they've had a negative mammogram and ultrasound, MRI still detects almost 15 cancers for every 1,000 women screened. So it's clearly a much better test than whole breast ultrasound. And certainly, if you're going to do you shouldn't do mammogram, ultrasound, and MRI. If you're going to do supplemental screening and they're eligible for MRI, I would do mammo and MRI because that's going to have a better cancer detection possibility. The best part about MRI, you can see the interval cancer rate is decreased by up to 80%. So it is finding a lot of these cancers in these women with very dense tissue. I mentioned some of the cons for those contraindications, the fact that there are going to be some false positives, but our positive biopsy rate is very reasonable. It is definitely more expensive, though, than ultrasound or DBT. The actual, how much do things cost? Of course, we really can't give you a cost. It's more like what are they charged? But this is probably 10 times more than a mammogram is what I would estimate it as. And it's also less widely available. Um, there's a question in the chat about do we use contrast with ultrasound? We do not routinely use contrast with ultrasound at this time. Now, there are some ultrasound agents. People are doing research on them to see if contrast enhanced ultrasound would have any benefits, but nobody's using that for for supplemental screening at this point. And then in terms of the MRI, just so people know, if you're going to do it, typically most places alternate the mammogram and the MRI at 6-month intervals. But there was a recent study showing that if you perform them at the same time, you might actually increase your sensitivity to the highest possible level. So pros and cons, but I say most of the time, they're alternating them at 6-month intervals. All right, let's move on. So the other thing that's coming, or many more centers now adopting, is something called contrast enhanced mammography. And what's great about this technology is that it is going to be having a sensitivity and specificity that's very comparable to MRI, but it's a much less expensive test because basically it is a mammogram. And instead of just taking a 2D picture, you're taking what's called a dual energy acquisition. So, because we give the patient a contrast through their vein that has iodine in it, we can acquire an image below the K edge of iodine. So, we're going back to basic physics, and that will give you your picture here, which is the two-dimensional mammogram. And then you take one above the K edge of iodine, and you can subtract those two to see what actually is taking up the contrast. So, Mindy, just click one more time. And so this is the recombined image. And what it will do is just highlight anything that took up the contrast agent. And here you can see there's actually a rim enhancing irregular spiculated mass. So this is just this focal asymmetry here turned out to be a very suspicious finding on the contrast study. And this was a high grade invasive cancer. So the way these get interpreted, I mean, they're very quick and easy to interpret is because you use the lesion morphology based on this, and then we look at the contrast enhancement pattern in order to characterize them. The thing to know about contrast enhanced mammography, it is approved for diagnostic work. It has not been approved for screening, but I will tell you in practice, there are some physicians now ordering it for supplemental screening, particularly in women with dense tissue, as well as particularly for breast cancer survivors that have dense tissue. Those are the two areas that I've seen it being used, but it's not uniformly being used for screening. Next slide. So pros, high sensitivity, high specificity, pretty similar to MRI in terms of the interval cancer detection, somewhere between probably 12 to 13 per 1,000 women screened. Very high negative predictive value, which is actually very helpful for me in the diagnostic setting. I'd say this is a very quick and easy study to perform. It does require to have the IV put in, but there are several studies now from women who have been undergoing supplemental screening for years. They much prefer to have a contrast enhanced mammogram than to have the MRI. It also is real-time interpretation. What are the downsides? The contrast we use, although it's very safe, it is the same that we use for CT scans, and it does carry a slightly higher risk of an allergy than gadolinium. The radiation exposure is going to be a little bit more than just a regular mammogram, but that's still within reasonable limits. If you want to see the axilla or the chest wall, you're not going to see it on this test. That's why you might want to do an MRI. And it can, just like anything, even like MRI, miss a low-grade malignancy. But it is a really, really good test. And, much more, I'd say, once a facility gets the actual software that would allow them to do this, it becomes very easy to do because everybody has a mammogram machine. It's just a matter of upgrading the equipment with their proper filters and the software to process the data. So let's go to our final modality, molecular breast imaging. So this is not a widely available approach, but there are some centers in the Midwest that are using it pretty routinely now for both diagnostic and for supplemental screening. It does require injection of a radioactive tracer. The one that's being currently used is sestamib, and it will accumulate in cancers more than the benign tissue. The imaging does take about 40 minutes, and the breast is mildly compressed, so it's not squeezed quite as tight as a mammogram. So there is some benefit there because many women don't like a very tight squeeze. So let's go to the next slide. You can see that it does definitely pick up some cancers, but the cancer detection rate, at least in some of the earlier studies, has not been quite as high as contrast enhanced mammography or MRI. But I do think this approach has some promise because there will be probably more specific tracers that could be injected down the road that may, really be advantageous. But I personally believe we're not quite ready to use this in prime time routinely. The radiation exposure is definitely higher. It's about 4 times that of a mammogram, although they are working on trying to reduce that. And is, as I said, not been widely adopted at the present time. But, for those who do it, they really, it does find cancers. Next slide. Now, I added in this because actually this study just came out literally last month. It comes from the United Kingdom, and it was a very interesting study. Just you have to keep one caveat in mind. They screen every 3 years over the United Kingdom, but they had almost, a little over 9,000 women in their study, and they were comparing basically MRI, whole breast ultrasound screening, and contrast enhanced mammography in women that had a negative mammogram. They were average risk and they had dense tissue. And I thought this was actually quite fascinating because what they found is that, basically MRI and contrast enhanced mammography clearly outperformed whole breast ultrasound in terms of finding additional cancers. And, but you can also see that there were some adverse events, and particularly with the contrast enhanced mammogram, there were some contrast reactions. Most of them were very minor, probably, hives or a little bit of nausea that happened after the contrast was given, but they did have one severe contrast reaction. The other thing to note in the study is that the cancers that were found by MRI and contrast enhanced mammography were half the size of the ones that were found on the ultrasound. They were all pretty much node negative except for a few, but the recall rate from MRI and contrast enhanced mammography, at least in this study, was actually higher than whole breast ultrasound screening, which was kind of interesting. But interesting. There's going to probably be a lot more data coming out from this particular study, but the screening interval that they do is very different than what we do in the United States. So, next slide. And then I wanted to end with this slide about AI because there's a lot of artificial intelligence and machine learning going on. And I actually think this is going to definitely impact, not necessarily right now, but down the road will help us figure out who should really be getting supplemental screening. And these were two recent studies that have come out of one out of Sweden and one out of England, where, very large number of women negative mammogram, and they put them through a risk prediction AI algorithm. So their mammogram was run through this prediction algorithm. And basically, the ones that had the highest score underwent supplemental MRI, at least in the Swedish trial. And you can see they found an additional 64 cancers for every 1,000 women they did. Huge number. They basically found 63% of the expected interval cancers of their entire screening population. So just by targeting, by using the AI to tell them these are the highest risk women with dense tissue, they were able to really, I think, dramatically reduce their interval cancer rates. And similar study in the UK where they used a different risk prediction, so there's a lot of risk prediction algorithms out there now, but this Mirai one that actually was developed here in Boston, and they picked up an additional, 42% of their interval cancers by triaging patients and saying that these patients needed to have the supplemental screening versus others probably were not as high risk. So I think AI down the road is actually going to be coming into play, but there's still a lot more work to be done with it. All right, so next slide. This slide, just for those, I think this is a really nice schematic that is actually on the densebreastinfo.org site, just sort of summarizing what we just went through. But it's really visually shows you that MRI and probably contrast enhanced mammography are definitely the best modalities we have currently to find additional cancers in women with dense tissue. If we're going to be doing supplemental screening. There is still value in doing ultrasound if that's the only modality you have, or that's what your patient is only able to have for whatever different reason. But it clearly is not as good as those other two modalities. And next slide. And then I'm going to end here. I'm not going to go into this in depth because I know Dr. Battaglia is going to come back to it in the next session, but just to share with you some of the guidelines that have been developed by multiple different organizations and societies. And you can see that majority of them do have guidelines for supplemental screening based on a patient's overall risk. And risk includes dense breast density, but there are also actually societies and organizations that do have existing guidelines solely based on breast density. And I'm not going to go into the details, but I sort of bolded and showed you that basically MRI is pretty uniform across most of them. The National Cancer Comprehensive Network does mention ultrasound as an option. And I think all of these actually, if you really read the guidelines, do mention ultrasound as an alternative to MRI, but usually will preferentially suggest MRI. Interestingly, just to also point out, the United States Preventative Services Task Force here, notice they're the outlier. And they're an outlier for a whole bunch of different reasons, and we don't have time to get into all those details. But part of it is because that particular group did not have any breast specialists on it or people that even deal with breast cancer or breast disease that were on that group. Number two, they included data that, particularly a Canadian study that has now been invalidated. Even the people that did the study have outspoken out about how the study was not done properly and therefore the data is not reliable. But they continue to put that data into their analysis, and that really lowers their ability to really look at the evidence, I think, appropriately. But, pretty much you can see that there's growing evidence that there is a need for supplemental screening, particularly in women who have dense tissue. So I think we're going to end there. I think the next slide is just a thank you, Mindy. And then I know there were a lot of questions coming up in the chat. So let's see if we can go back and maybe start answering some of them. Um,
Yeah, so the first question I'm seeing here that you covered, but let's revisit it. In case of very dense tissue, would ultrasound be better for screening? I'm assuming it's ultrasound versus mammogram.
Right. So the only modality that's ever been shown to reduce mortality is mammography. So, an ultrasound's not going to replace a mammogram because they're looking at different things. However, ultrasound, I mean, I think MRI, if they're extremely dense, most of the guidelines now, if somebody's extremely dense and even if they're average risk, there is now sufficient evidence to say that those patients should be at least considered for MRI screening. But, for example, I know Dr. Battaglia works in Connecticut, and there's a state law in Connecticut that requires them to do a whole breast ultrasound screening. It's actually in the actual state law. They put the actual modality in it. So women with dense tissue, whether you're heterogeneously dense or extremely dense, are supposed to be getting both mammography and whole breast ultrasound. But I would argue that there's really not a lot of benefit to do the mammogram, the ultrasound, and the MRI. It's much better to just do the mammogram and the MRI. So I personally would say skip the ultrasound. But, the other thing I would say is like, I think last session somebody brought up that, they are up in a very rural area, and there's no access to MRI, then clearly I would do ultrasound because that is your next best modality. And maybe down the road that facility or you'll be able to offer contrast enhanced mammography, which personally that would be another reasonable option if that's available. Because at some
Priscilla,
point, yeah.
can I ask a follow-up question to that that's related to the ultrasound? So I think just to reiterate what our main takeaway, which is that MRI is superior to ultrasound for supplemental imaging based on all the data you just presented to us. But I'm curious about, and I don't know if I fully understand, so maybe you can help me,
Okay.
why we recommend MRI at the 6-month interval, but ultrasound at the time of the mammography. Is there like science behind that? I don't
So
want.
yeah, so that is a great question. There is absolutely no science. Okay,
Okay.
this is why when I was involved with helping develop MRI many years ago, and what was really fascinating is that there is no science for some reason. When MRI came into clinical use, after we showed it could actually find cancers, I think providers thought it might be beneficial to see patients more frequently, particularly if they're high risk. So they decided to start alternating the mammogram and the MRI. Personally, I mean, as I said, there was a recent study showing that your highest sensitivity is going to be, sorry with that, when you do them at the same time.
That's helpful. I'll just share anecdotally, like from my clinical experience as a high-risk breast provider, it's very hard to take away an interval test from patients who are used to getting it because it makes them feel like, they're being followed. And why would you take that away from me?
Yeah.
And the interval piece. And so anyway, it's just,
Yeah, no, it is very interesting, but there is actually no science. I've never seen a
yeah,
study showing doing them alternating in 6 months. I do think, though, psychologically, it
yeah.
might make patients feel, particularly the high-risk women, feel a little more comfortable that they're being checked on every 6 months, right? But it actually is, I would wonder if there's a way that we could study that because so many women now have had probably, but we probably don't have enough in the same, getting them at the same time to be able to compare cohorts. But It's probably fairly equivalent, but I do think there's probably slightly higher sensitivity if you do them at the same time point, but it's okay.
And I wonder, I'm thinking about from the referral perspective, I wonder if it's easier for a primary care referral to be made at the
Oh,
same time versus having to flag a patient that is documented as a, over 20% lifetime risk and need to make sure they get the second referral after the mammogram. Just something, I'm thinking about the primary care providers that are on, and that it is an additional
yeah.
referral, and usually it's like the domino starts when you get the mammography results back to then schedule the 6 month.
Yeah.
Yeah. It does make it logistically challenging. There are other questions. I'm sorry I derailed.
I'm gonna go on another question. So there was, I mean, I skipped over a few because we answered them, but I think Nancy put it in the chat, are there efforts to get the FDA to approve CEM for screening? So to get something approved, that's quite first of all, I would say a lot of what we do in medicine is not FDA approved. Like technologies or tests come in, they're approved for certain indications, and yet as we start using them, we start using them for other indications, and that's not necessarily even linked to whether or not insurance companies will pay for things. I don't think we necessarily need to get the FDA to approve it for screening. Um, but the Find It Early Act is to cover all supplement. It doesn't indicate what modalities really. It's going to talk about all modalities because who knows what we're going to have 20 years from now, right? I mean, like that's the with legislation it's really important to keep it very broad so that whatever is indicated is covered. And for contrast enhanced mammography, the way that, there is no actually CPT code for it right now, and that's a whole nother discussion, probably too much for to go into at this moment. But we do bill for it and it is covered. It is billed though as a diagnostic mammogram as well as with the contrast. But we have not had issues, at least in Massachusetts, getting it covered, and many other people are doing the same. It's just there's no screening code for it, unfortunately. There's just no way to bill it as screening. Nancy, you're muted. Nancy, you're muted.
That means the provider has to order it that way then, right?
No,
As diagnostic?
they just order a contrast enhanced mammogram. The billing part happens behind the scenes. But I think for the patient who potentially has a copay or deductible for a diagnostic imaging, like in my state, they wouldn't, right? Because we just passed a bill that covers that. But there are some states where women still will have to pay some out-of-pocket cost potentially for that study. So.
Do you think contrast detected mammogram will start to show up in the guidelines? I mean, you talk about the FDA, but it's not called out in the guideline chart.
So I can tell you in the American College of Radiology guidelines, although I didn't put it in that chart, contrast enhanced mammography is listed in their variant tables. Um, at this point, there's growing evidence for certain groups that it is got benefit, right? But
Got it.
those guidelines are always updated continuously, I would say. So they're constantly changing, but they're based on the evidence. So it is a relatively newer approach. Therefore, there's not as much evidence, and therefore we have to go with what the evidence shows. But it is actually in those guidelines, and it is mentioned as a may be appropriate for most of those situations, which means it does work. It's just we can't say it's the test of choice per se. But I have seen patients, like for example, the women particularly who are high risk, who many of them have dense breast tissue as well, not all, but some of them prefer to actually alternate between contrast enhanced mammography and MRI for a variety of different reasons. Some are worried about gadolinium retention, which was a concern a few years back. I don't really think we don't think there's any downside, but there is always a bit of gadolinium that's retained in the body every time it is administered. There's no thought that it has any negative untoward effect, but for some women, they're concerned about that and they prefer to alternate year by year. Some, prefer to have contrast enhanced mammography just because it's more comfortable. They find the MRI very difficult to lie on their stomach. So there's a variety of different reasons, and they do, it definitely is a good alternative, and particularly, somebody who has a contraindication, it's a good thing. Would there be a fair way? I'm just looking at the other questions. So I think Shannon put in, said, when she's asked about one type of breast imaging better than the other, she replies that, one test isn't necessarily better than the other. They just look at the breast tissue differently. Um, and I would say in general that, I think definitely, I think there are some that are probably more sensitive than others, but I think your statement saying that they do look at the tissue differently is absolutely correct, right? They all are using different kind of approaches to look into or inside that dense tissue. But I think we've gone over some of the benefits of, or of some of the modalities more than others. So what is this?
But
Is
just to clarify that question, if you're talking about supplemental screening, but if you're talking about like routine screening, mortality data is only available for mammography. So
correct.
that's always my go-to sort of statement. Like if we're going to do anything, it's going to be mammography
Correct.
as a baseline. And if you have dense tissue and you don't, we assess your risk, we could have another conversation, but I always that's kind of my default response.
Yeah, no, I think that is a good response. The other question that's here is, and I think Marlon put this in, not sure this has been discussed, but is there research on the impact of increased radiology exposure on women prone to radiation sensitivity and its effect on cancer risk? So, the first thing to keep in mind is that the dose of radiation that someone's exposed to from a mammogram is extremely low. I mean, it's a very highly regulated field. And you actually get, believe it or not, I'll never forget my public health school class where the professor was up in the front of the class. He said, if you fly transcontinental or transatlantic, you get the exposure of 5 chest x-rays. I was like, oh, and a mammogram is nowhere near a chest x-ray. So no, so the amount of radiation that women are receiving from a mammogram is extremely minimal, and it's highly regulated field. So no one believes that having a regular mammogram, an annual mammogram, increases your risk of having cancer. Now, radiation therapy, that's another story. Your risk does increase if you're having radiation to your chest. Um, particularly if you have radiation to the chest when you're in your, teens and 20s. And those women are at significantly elevated risk down the road for developing a breast cancer, and they're considered high risk, and we screen them, with supplemental screening. Um, but so there's no known, risk at this point.
Thank you. Miss Molly, do you want to share about the
I do. So this is a new resource, and we'll mention it again when we kind of go into the different risk assessment models and, who will benefit more from which model. But we want you to know that our ACS National Breast Cancer Roundtable has put together a risk assessment toolkit. And it's really around how do you implement a protocol for risk assessment within your practice. And there's flow charts and there's a readiness assessment tool there's great tables that list all of the available risk assessment models and who's included and everything, and we're going to go into that. But we want, as you come to these sessions, we want you to know about the latest resources and tools, particularly for implementation of risk assessment. And so this is there. We'll go into more of it, but you can always come back to the slides and get this link.
Great, thank you. And so now we can actually open it up. We have I'm going to go ahead and put the survey slide, survey link and case presentation link in the chat. I would like to use the rest of the time today to have discussion. So I'm going to skip over my slides for you, but I'm doing that. But you have to promise me that you will take the survey. I am putting the link in the chat. But let's use this time for case discussion.
So this first question on here, we don't have a case. We want you to know that if you have a case, please sign up. It's super easy. We'll make the slides for you, or you can just talk through the case. Mindy just put that form in the chat, so check that out. The first discussion question was on one of the surveys, the post session survey. How often does a woman need to have an MRI screening if she has a family history of breast cancer? Mother, maternal aunt died, first cousins diagnosed, one died, etc. BRCA negative, mammogram done annually. What say you, panel?
I mean, I can try to take a stab at it. So, I mean, I think it's a complicated question. And I don't know that I have all the information that I would want to have to be able to make a recommendation. As we'll talk about in the upcoming sessions around supplemental screening guidelines, spoiler alert, there are no agreed upon, recommendations across all of the professional organizations. So there's a lot of, ifs, buts, ends, associated with the response to that. There is general consensus amongst most professional organizations that supplemental screening with breast MRI is indicated when there is an elevated cancer risk and dense breast tissue. And so if that's the case, you're making the decision to do supplemental screening based on, and I don't have enough information with that question to say what their risk is. There are ways to calculate a risk. And I don't know what their dense tissue looks like, or whether or not they have dense tissue. But if we decided supplemental screening was an option, then MRI screening could be something that is done annually or biannually. And there is also not consensus around that. More recent modeling data, and Priscilla may have more up-to-date information on this, suggests that biannually may be as good as annually, in terms of sort of benefits and sort of reducing sort of potential risks with false positives. So I don't know, Priscilla, I'm happy, or others, to hear your thoughts on that.
No, I don't have much to add to that. I mean, I think this question is very complicated because we don't have all the information we need. But if you're going to be doing supplemental screening with MRI or with ultrasound, it is done annually. Now, but that's just how we started doing it. Does it have to be done annually? I mean, if it's a very, very sensitive test, maybe we wouldn't have to do it annually, but right now we do it. And that's sort of what most of the recommendations would be. As I said, I brought up AI. Who knows how AI is going to impact that? Because, as we introduce these risk prediction models with AI, and if they get better and better, that may alter how often we might need to be imaging somebody as well. But we're not there yet. So for right now, if they're eligible based on their risk assessment, then most of us would be doing MRI at this moment.
So would the next step for this patient be to do a risk assessment?
Yes.
That's what I would say. Yes,
Yeah.
sure.
All right, next one. A 52-year-old woman with heterogeneously dense breasts and average risk for breast cancer. So I take that to mean they have done a risk assessment and they don't have, based on the risk assessment, they don't have a 20% or higher. Has a negative digital mammogram. She expresses concern about miscancers due to breast density, what supplemental screening options would you consider for her?
So in the state of Connecticut, where I practiced for the past 2 years, they would automatically get an ultrasound at the time of their mammography without an order from me as the primary care physician. That's unusual, I think, from a professional guidelines perspective, which we'll go over next session. The ACR recommendations do suggest that there's potential benefit of ultrasound, supplemental screening for in average risk women when there's extremely dense tissue, but not necessarily when there's heterogeneously dense tissue. And so for this particular patient, with the information that we have, the professional organizations or guidelines wouldn't suggest supplemental screening.
Right. Well, and I agree with you, Tracy. I think, but I think you'd have a conversation with the
Yeah.
patient, talk to them. And, I do know of some women in this situation who, after you have that discussion, they do want to proceed ahead with something additional. And but with that understanding that now it's not necessarily supported fully by evidence, there may be some out-of-pocket costs that come with that. But I do know of people, I mean, often they'll opt for if they can get access to a contrast enhanced mammogram because the cost of that is really minimal in the sense compared to like MRI. So, or they'll do an ultrasound, which is going to be much less expensive if they have to end up paying out of pocket. But there is really not enough evidence to support for average risk and heterogeneously dense. Now, if they were intermediate risk, there are some of the guidelines suggesting intermediate risk and heterogeneously dense would be potentially screen or undergo supplemental screening with MRI. So the risk assessment is really the key piece here.
And Priscilla, by intermediate risk, do you mean like 15%, like in the 15 to 20
15
range?
to 20%. Yeah. Yeah.
And,
I think,
and also like having one of the, which you'll all learn, not every risk assessment tool model out there ask about breast density. And so, making sure if you have a patient who's concerned about breast density, making sure that you're doing one of the risk assessment models that has that. And
okay. So Molly, before we go, can we just look? There was one more question
Yep.
by Eva, I think.
Oh,
Yep.
In the chat, I'm just talking about, is there benefit for ABUS, which is the automated ultrasound versus traditional bilateral whole breast ultrasound? The advantage of automated is it's standardized, right? So if it's handheld is very, or potentially could be operator dependent. I'm not sure I've seen a lot of data one way or the other, but I think that practices that offer whole breast ultrasound done by a technologist or a radiologist, they're experienced. So they're probably simulating that automated approach. So I think they're pretty equivalent, to be honest, if you're going to be doing that.
excellent. All right. I see we are at time, so I'm going to take 15 seconds to say, take your survey. Please, please take your survey. It closes December 9th. And then please make sure that session 4 is on your calendar, where we will hear more from Dr. Battaglia. Thank you all so much for your time today, and we look forward to seeing you next month.